Good afternoon to everyone on the East Coast and in the Central Time, and good morning to everyone in Mountain and Pacific Time. As I mentioned a minute ago, I'm Dirk Bocolo. I'm the host for this, the second leadership meeting, our Behavioral Health Integration Learning Community. Today I'll be joined by Roger and Laurel. They'll both continue on the, or we'll be about the business model, along with going over some of the work that you all did over the past few weeks and over the holiday break. Everyone had a very relaxing and wonderful holiday break, and Happy New Year to everyone who's joined. So I'll say we'll get started. As usual, we'll start with our roll call. I will do the usual thing of unmuting everyone, so if you can keep yourselves muted locally, that'd be great. Just as a fun little technical thing I figured out in the past week, if you're just calling in and you're unable to see the PowerPoint slides, you're always able to unmute yourself by simply pressing *6 on your phone. And anyone who's called in and is viewing the PowerPoint can do that as well. So if for some reason you're unable to unmute yourself, just hit *6 and then you can always chime in. So you're welcome to do that. And it's also *6 to remute yourself, which is very easy. All right, let's get started. I'm going to unmute everyone and we'll get the roll call started. All right, first is Access Family Healthcare. Are you with us?
Yes.
Hi, welcome. Next we have Corning area. And in Corning. Next we have Custer County. Anyone from Custer County? We have Flathead Community Health Center. Flathead? All right. GA Carmichael? And from GA Carmichael? Nope. Okay. Georgia Mountains Health Services? Hello? Yes.
This is Access Family Care. We got disconnected and we just backed in, so we're...
Oh, thank you. I want that to happen to anyone else because it's been kind of quite... Looks like we have quite a few people on, but I haven't heard from anyone yet. But if for some reason you did miss the roll call, feel free to chat in the chat box and let us know you're here, especially if you have a alphabetical health center name near the top. I believe next was Heart City Health Center. Anyone from Heart City? Hey, anyone from Manet?
I'm Denise from Manet Community Health Center.
And I'm so sorry. Someday I will learn how to pronounce it properly. I do apologize.
That's okay.
How about Mary Center for Maternal and Child Health? Do we have Mary Center on?
Christine Rupert here.
Great, Christine. Next, Mid-Delta.
And then Mark.
Hi, Susan and Marla. Welcome. Next, Myrtle, Hilliard Davies Comprehensive Health Center. Anyone of those? No. Northwest Community Health Center. Last on the list, we have Tillamook County Community Health Center. Anyone from Tillamook?
Yes, Marlene here, and Frank Williams, and I have our new behavioral health consultant, Barbara Weathersby, is here too.
Welcome, Barbara.
Thank you.
Can you hear us?
Who's this?
Yes, this is Cynthia Eula-Gray with Corning Area Healthcare in Arkansas. With Tom Ray as well. We are behavioral health consultants with Corning Area Healthcare.
Well, thanks for letting us know you're here.
Thank you.
So again, if for some reason you missed the roll call or you're not sure if we got you, feel free to just chat into the chat box and let me know that you're here, and we can ensure that we know you're on. So I'm going to move on. Just a quick overview of what we're talking about today. I'm going to talk about the extranet very quickly. There's one or two functionalities I want to make sure everyone understands and can use because it will be critical to the to how you submit your assignments and how we review the assignments and get them amongst ourselves. Then we're going to follow up quickly from call 1 about those assignments and look at what you came up with. And then we're going to get into the business case, sort of the meat of this this call today, and Roger will go over that. And then we'll just take 5 minutes to talk about what the action period until the next call is, along with a few housekeeping items as usual. So on that note, I'm going to mute everyone again, unless there are any questions. And like I said, you're all welcome to unmute yourselves at any time if you have something important to say. Click on your screen, the little red microphone. Or, again, just press *6 to mute yourselves if you're calling in. At this point, I will start with the Extranet tutorial really quickly because I think we're already a few minutes behind schedule. So we're moving into an accelerated period of accelerated activity. You're going to have a lot to do, and you have had a lot to do over the holiday period. And we want to make sure that we have a central database where you can locate all your files so that we can see them, and if you'd like, you can share them with other people in the learning community. As always, we encourage people to talk to each other within the learning community. It's not like we need to supervise everything you say to each other. You're welcome to send messages to one another as well as share information. So now what I'm going to quickly do is do a screen share and show you. This is just a screenshot for future information. I'll do a quick screen share, and then we can how you'll upload a file, as well as where you'll find one of the assignments. A second to load up. So this should look very familiar to everyone. This is our Extranet homepage. As every team has their own resource page in addition to the usual resources page. So this is our general resources page where we post everything that's relevant to everyone. But we want to also make sure that you can access your team page, which is where you can host your own documents privately. What you can do is under My Teams at the bottom, you should have your team. I'm obviously a staff member of NAC, so my team will be NAC. It'll look very similar for everyone. Everyone's team page. So in this case, any of the newest resources that you've put will be down here, but you can also click on the Resources tab up here to the left. These will be the resources that are just specific to your team. As some of you have already done, you've uploaded your Dolly Story to the Assignments tab. You'll look, by noon tomorrow, there will be an Excel sheet in the Assignments tab as well. This will have the business case worksheet that you can click on, download, and then we ask you that you re-upload it to the Assignments tab once you've done the work on that, which Roger will explain later as to what the worksheet is and what you're expected to do in that regard. But to add a resource to the Assignments tab, it's very simple. You just hit this Add Resources button at the top. If for some reason it does not show up, let me know. That means there's been some error in the system. Shouldn't happen, but you know, I'm unfortunately not perfect, so things happen. You'll hit Add Resources, and that can add either a document or a link to anything you find interesting. Documents, this is like in any other upload situation, you just need to give it a name, describe it something very simple, and then you'll hit the browser and you'll be able to find any of your, so example, continuing and unmuting instructions for WebEx, and you'll just save. It wants me to add a name, but you'll hit save and it'll show up on your Assignments tab right here in the Assignments folder. And if you have questions about that, you're always welcome to email me, or if you have any problems with the Extranet, I'm happy to help. This is your resource, and this is where we want you to upload the information that we have. So I have gone way over my allotted time, and I'm going to stop sharing and hand it over to Laurel now.
Thank you, Dirk. So what we're going to do now is move on to just a quick review of the action period assignments that we presented to you during our last call. There were two assignments you might remember. One was to create your Dolly Story, and another one was to start collecting data around the business case. So I want to start with the Dolly story. You might remember the story of a real person that Roger created a map for all the different services and connections she had to make in even a relatively simple episode of care. We received a couple of stories back from you. They weren't pictures. We don't have pictures, but we do have some stories. And I've included in our slides here the narrative stories that were submitted by Manet. Am I pronouncing that correctly? You'll let me know in a second. We'll ask Dirk to unmute Manet in a moment. And also from Myrtle, Hilliard Davis. So I just want to show these both to you and maybe ask Manet to speak briefly to their story. The story that Manet gave to us was about a woman in her 50s who has long been a patient of the health center, very high ER user with multiple chronic health conditions, as you can see. The problems that were identified for this individual is that she has many care providers and has issues with compliance with her medication. She has often gets lonely, and when she gets lonely, she calls 911 to go to the hospital. Diabetes is not well controlled with an A1C of 12.16. She's not great at taking her medicine and doesn't have access to a full kitchen. Barriers that were identified for this, that Manet identified for the individual, was that sometimes she has some unusual behavior. She'll hang up or just not engage with the care team if she doesn't feel like it. She doesn't have family, doesn't have great family support, and is not well off, doesn't have a lot of resources. We described working together as a care team, a coordinated team across boundaries of the organization to involve her specialists and community resources to provide continuous care, and they had specific goals, which is fantastic, to provide better outcomes for her diabetes, to reduce her ER visits, which were very high, and to improve her medication compliance. That there are a number of wins that through reminding, having the resources to remind her to keep her appointments, she has started to keep her appointments. She now has a visiting nurse that's going to her apartment and is intensive one-on-one therapy around insulin and blood testing and medication. Working better, more coordinated work with her behavioral health professionals outside the primary care organization. Perhaps most strikingly is this person has no ER visits since October. So I wonder, Dirk, if you could unmute, is it Denise from May?
I'm happy to unmute them, and if not, they're welcome to unmute themselves by, like I said, just pressing *6 should do the trick as well. Let's see, Denise, unmute.
I think it was Denise. Hi.
Hi, this is Denise from It's Minute. It's Latin for It Remains. It's the city motto for the city of Quincy.
Could you say it one more time?
And Manet.
Thank you. So I hope I characterized your story well, Denise. One thing I just wanted to ask you about your story is, as you and your team were developing the story, did anything useful for your integration work come out of it? For example, did you identify any new opportunities for implementing changes?
Well, I think this story and this example gives us, pause to look back and see the accomplishments that we've had over the past several months. We do have a care manager in on site 2 days a week, and we do not have any integrated behavioral health specialists here at Manet. So we need to take care of some things in house. It's very difficult to get this particular patient keep appointments with specialists and behaviorists. So we of her care is just done here, but she was able to make a connection with our nurse care manager. And nurse care manager has worked very close with her one-on-one, and able to liaison, if you will, between her, the outside specialists and her group home and the VNA and other services that she's eligible for, but often would not accept because of her behavioral health issues.
Thanks. That's great. Well, sharing that story.
You're welcome.
I think you also write towards the end of your story a wonderful thing here about how often we write off the patient as non-compliant when, in fact, with some of the careful coordination like you're able to do now, things really can get better. I asked Dirk also to set up the call today so that you, any participant on the call today, can flip back and forth amongst the slides by using the little buttons that are right here, the little black arrows pointing left and right. So if you want to go back and read a little bit more about Manet's story, Manet, I've got it now. You are certainly welcome to do that. We also had a great story submitted by Myrtle, Hilliard Davis, and Dirk. I think Dr. Kevin Turner is on the line. If you could go ahead and unmute Kevin Turner. Here was a client that was referred for behavioral health screening and really received some fantastic self-management support interventions at Myrtle Hilliard Davis, including some modest but important goals around reducing the amount of potato chips she was eating and adding a little bit of minimal physical activity. Finding that in her own medical neighborhood, her dad owns a store, and she might be able to do some work at his store, and that might increase her activity too. Some of the successes that came out of that was the patient has been able to cut down on her potato chips a bit, and she has started to take a walk around the block, which is wonderful. And I guess you'll be seeing this individual tomorrow for an update. Dr. Turner, is there anything you'd like to add to that story? Anything that you and your team learned about the care system by developing this story?
Good afternoon. I'm going to have Flo Terry, the behavioral health consultant, to discuss it. Okay.
Thank you.
Sure. Hi, how are you doing there?
Good. How are you?
I'm sorry. I'm well, thank you. Actually, we were able to learn some things in terms of working with our patients in a collaborative effort as a team. And through doing that, even though she was referred to behavioral health for physical conditions, through the consultation, and actually we did talk with each other yesterday. We had to do follow over the telephone. She also indicated that she really does need to talk to someone about her depression, and feels that is preventing her from increasing her level of motivation to continue to maintain things like her hypertension as well as reduce her weight. So she also indicated that she wasn't really willing to discuss those issues during the first time we met, but through talking with me and her doctor, she's now willing to really take a look at her depression and how it's affecting her overall health. So it was just wonderful, and so we're really going to plan to follow along and see what happens with our client and in terms of achieving her goals.
Terrific. For sharing that.
Sure. Thank you.
This can be really uplifting. I just want to finish this section by just reiterating the value of having a Dolly story. The stories that Manet and Hilliard Davis shared were great success stories around behavioral health integration and coordination of care. The story that Roger started with was really the chaos of the system that exists prior to some of the successes that Myrtle, Hilliard, Davis, Manet, and many of you are also experiencing. And I just want to reiterate why it's a valuable idea to take the time to do an exercise like this. Key amongst central amongst the benefits are staff engagement, staff buy-in and understanding. If you haven't already done it, if you do a Dolly story, please think about engaging as many of your staff as you can, particularly maybe those staff members who you're having trouble getting buy-in from. A couple of you in your pre-work assessments mentioned that buy-in is still an issue for some of the staff. Also, by creating the story, the chaos that exists now from the patient's perspective, there really can be moments for staff to say, oh, I see, there really is a problem to solve. And, oh, I really see, now I see, I have a picture of what problem it is we're trying to understand. You may remember that last week Roger introduced the leadership framework that we're using for this call. And you can see right up at the top, under step 1, the very first step is to make the status quo uncomfortable. What that means is to really make visible all the problems that are existing now and the problems that you're trying to solve. This picture of Dolly and your own Dolly stories are the status quo that is uncomfortable. It's the problem that you want to solve, and it's a key element of leading change for your organization. Dolly story can also be the center of your communication strategy. We've talked a little bit, and we'll talk some more about how important it is to have a pretty well-developed communication strategy for what you're trying to do around behavioral health integration. And the Dolly story can be a living document. It can start as this chaotic mess. It can even be posted in the staff room. And as your organization is able to create a much better looking story for Dolly or your own Dolly, it can really be the anchor for the touch point for what it is you're talking about and trying to communicate. Of course, the Dolly story reveals lots of opportunities for reducing wasted time and effort when people start seeing how many times they have to redo something because it's not getting done right the first time. They can also identify hidden external and internal resources. The Dolly story includes, for example, strong support that Dolly was getting from members of her church. I know a number of you already are reaching out into the community. All of you have medical neighborhoods that you're working with. Sometimes find new ones by really following, not just imagining what Dolly has gone through, but really sitting down and a specific patient's story and talking to him or her, finding out all the different things that she has to do to get the services that they need. I can help setting priorities. So I would encourage you in this time of intense activity. We've just got a few months together, and would like you to be able to push forward as much as you can in the leadership portions of behavioral health integration. Would encourage you that creating a Dolly story is a valuable way to spend some time. I just showed you the leadership framework. The second item on the leadership framework that's very important that we also asked you to talk about, also asked you to review a bit during the action period between two calls, was to start to develop the business case. This is an important item under number 3, building will. Basically, the things that we asked you to do was to start trying to collect a little bit of business case data. So we asked you to see if you could find what is the average net collection or the average net revenue you get for each patient visit. What the production cost? How much does it cost to have a patient visit? And also calculating the business case impact. Basically, that's just the revenue minus cost. And if you were at an annual, if you were to add one patient visit every day for 1 year, how much would that add or detract from your revenue? I asked you to begin collecting some data on estimating how much time, how much burden is taken up by the behavioral health issues of the primary care clients that you see. And so we asked you to estimate, using guesstimates if you could, about how much extra time is added to a patient visit when that patient has behavioral health needs. And if you could, translate that into the time spent per year by estimating the number of patients with behavioral health needs and how much extra time is taken up by each. What I want to do right now is a question about whether or not you were able to collect any of this data, whether it was really difficult or it was pretty clear, you know exactly where to find it. So, Dirk, I'm going to go ahead and do I need to hand the ball to you so you can open the poll?
Should be fine. I can do the poll from here. Let me just find it to open it. Okay, it's just so an interesting little tidbit for this poll. Notice that we added sort of a second part to it. That is that it's an ended question. So part 2 is where if you choose other, you can specify why you chose other down there as well. But if we get a few people who answer other to this question, then we will also unmute you and allow you to comment and discuss it as well. So the polling question is, did you have any challenges in collecting this data? And it's very simple. You were able to collect all the data, or you were able to collect some of the data but not all of it, or you haven't had an opportunity to collect the data because of the holiday schedule, or you're developing your own model of the business case for your organization. Of course, if you have something else that fits in, please do select other and let us know in the open-ended poll under enter other here. So we'll just give you a few seconds to do that. Once again, the poll should be right side of your screen, and just if you could select one of those or take a moment and think about it. I see most of you are in progress, but there's a few of you still that haven't started yet. Say we give about seconds or so for people to put those answers in and to compile the results. So, Laurel, if you'd like to say anything else in the meantime, feel free to.
So, as Dirk said, just choose the answer that's best. If you're having any trouble, if the poll isn't working for you for any reason, go ahead and raise your hand or chat in, and we'll unmute you and see if we can solve any technical issues. Every once in a while, poll will have a little technical issue.
And don't forget to hit submit. We've had people to the poll question, but don't hit submit, which is important.
Thank you. Thank you for reminding me, Dirk. This button is in the bottom right-hand corner of the polling box. So to let you decide when to close the poll, because you can see who's answered. I cannot.
No, we have about 10 seconds left, and then it'll compile the results, and we should have an answer in T-minus 7, 6. And there you go. You should be able to see them.
So everybody should be able to see in the bottom right-hand of their screen a small polling box. We didn't see anyone who was able to collect all the data, so that's interesting. We're going to talk a lot more about this data today in a moment, but we also want to work with you intensively over the next couple of weeks to help you do this, because it's the kind of stuff you're going to need to develop the business case. A few people said they were able to collect some. About 5 people said, yeah, you know what, the holiday skills really did get in the way. It's been really hectic the last few weeks, probably. And other. So, do you know if the person who answered other, did they also enter some text? I don't see it here.
It did not enter any text.
Okay.
I'm not able to see who that specific person is, but they're welcome to raise their hand and explain their choice as well.
Sure. Okay. So I appreciate your answering this question. This really helps us know how to follow up with you and give some additional support where it's needed, answer any questions that you may have. And we're not going to go too deeply into it right now, but because Roger's about to explain each of the business case elements in detail, but this gives us a good foundation to start with. So very much for that. Hand it over to Roger now. and we will start diving into this business case issue more deeply.
Thank you, Laurel. Can you hear me okay?
Yes, I can.
Great. Well, buddy, earlier in our first call, we did some polling of your interests and priorities, and one of the top issues that came up was concerns around your business case and sustainability. So we revamped our curriculum to move that to the front end here, and recognize that many of you are probably struggling with this issue and are looking for some help, some insights, some tools and resources. And so we're going to drill down today on the business case. I'm going to offer you a tool for you to help model your own business case. We'll explain the tool, and we'll be an assignment where you can go home and practice the tool and modify it, adapt it to your environment. So we looked at the business case. We also have a monograph that will be coming out that we'll be delivering to you that walks this business case through for your organization, and you can use that to engage other stakeholders in your organization as well. So the business case issues, we know that historically funding for behavioral health has been woefully inadequate, and the environment has yet to catch up with that fully, although we're starting to see gains, some gains coming from the Affordable Care Act, some gains coming from progressive efforts at the state level, but still some time to come. The case, the actual making the case, is a real challenge for organizations in understanding the variables. So what we tried to do is make this relatively simple and be able to offer you a framework to begin to document and understand your business case and have a basis for communicating with your finance team, with other stakeholders to better understand the case. So what the business case basically comes down to is that the cost of implementing your behavioral health services and integration, which includes your staffing and any equipment, any changes to technology, any transition costs, all those costs have to be equal or less to the revenue you get from integrating behavioral health in order for you to have a viable business case. Now, in some cases, the cost may be slightly more, and you as an organization make a strategic decision that you're going to make that investment knowing that you have to subsidize those services from other resources, whether it's grants or other pieces. By being able to start to model this, we can go through and better understand the business case. I'll go through each of these different components, and then we're going to show you a spreadsheet tool that we'll offer you. It'll be on the Extranet, as Dirk said, tomorrow, so that you can begin working with it and adapting it to your own environment. So let's go through the cost side first. The cost side obviously depends upon your model for integration. If you're in a co-location model with another organization, you may not have the staff cost embedded in your organization, but you may have other costs that are incurred. So there's a cost of screening side, which includes the cost of integrating where possible into your existing workflows. A starting point is always to look at whether it's possible to integrate these functions into existing workflows. So when you think of someone coming into the clinic, an example of integrating it into the workflow would be the person presents at the front desk and is there to register, that while they're waiting in the waiting room, they have the opportunity to administer a screening assessment tool that can be done right there at the point of service, and that information collected by the front desk people. That may not require additional staff. Obviously, depending upon the health literacy and complexity of challenges with your patient population, you might need a resource. So that's something you have to determine. But it was an example of integrating to existing workflow. But in the front end, can you integrate it into the exam room? So when the patient is moved and is waiting for the member of the care team to come in and is in the exam room, you have an opportunity to do screening, and can that be built into an existing workflow with the team, whether it's a medical assistant, whether it's a nurse or someone else on the team being able to administer. Do you dedicate resources? We heard from Dr. Brown in our first training session a model of using entry college graduates to do screening on site, and that can be a very cost-effective model. So you need to decide whether those kind of dedicated resources are going to be involved. And then in all of that, you have to factor in the salary and benefits for those individuals into your basic cost model. So cost of screening, and then there's a cost of intervention. And this may assume that you're adding additional staff to do that, either a social worker or psychologist, a behaviorist, could be other resources. Really depends upon your state scope of practice, your state licensure requirements, but this is typically where you see a lot of the investments. Again, you're in a cohabitation model with another organization. That resource may not be on your payroll, but in terms of modeling the overall cost, you might want to factor in those resources that are going to be required. There's the transition cost, and that should include training time. So say that in this new model, you have to take some downtime where you take your care team and you train them on the new workflows, you train them on how to do a warm handoff between the care team and the behaviorist, train on the screening protocols, training on decision support tools with interventions, management of depression, or other pieces. So that training time, you'd want to factor in the salaries of the staff that are participating in that. Is there lost revenue during that training time? Is the training time being done at the same time that you would normally have collected revenues? Are you taking an hour out of a schedule and doing the training? You'd have to factor in that lost revenue for that particular hour. And is there any potential loss in productivity during the transition period? You're integrating your model. Are you seeing early on, as you're doing these warm handoffs, a little bit of a dip in productivity as you burn in your new workflows and systems? You might actually, the reverse, there might be an increase in productivity, but factor that in at minimum to understand your costs. Three variables are something you can stack and model. You can start to put them together and better assess what these costs are, and then begin looking at what the revenue side of the equation tells us. So revenue side, we can step back and say, okay, well, what revenue would there come from the front-end screening? Is there revenue available from Medicare, Medicaid, other payers? Again, this is going to be very dependent upon your state reimbursement environment. We do know that Medicare is currently reimbursing for brief screening, and so that is one payer source. Medicaid may or may not. I know several states, there may be a direct reimbursement. In other cases, they're not. And in cases, that reimbursement may be bundled into a per member per month patient-centered medical home reimbursement rate that you can take advantage of. So you have to really figure this out for your particular environment and your situation, and that means reaching out and doing your homework with the Medicaid office, with the other payers that are available in the state, and really drilling down and seeing what the reimbursement level might look like. And we'll do this on a spreadsheet in just a second. Revenue from gains in productivity is the hidden gem, if you will, in the business case. It's something that most people don't factor in. We don't fully appreciate the impact of behavioral health on the day-to-day workflows. A colleague of ours who was CEO of a health center down in South Carolina, as they began looking at their panel of patients, they did a universal screening for a short period of time, believing that the incidence of depression across their population was probably consistent with the evidence base, which was suggesting somewhere between 20 and 40% of people with chronic conditions, and found was 70% of their population actually experienced some level of depression with their chronic disease management. They implemented universal screening and began to start to test a model of integrating a behaviorist into their care plan, and we're struck by huge leaps in gains in productivity because so much of the clinical visits were taking up dealing with the anxiety, dealing with the depression, dealing with the social determinants of health issues. If that could be offloaded, that would free up time to be be able to capture revenue. So the aim here is to look at how you can set up a system where you're able, in the middle of an encounter, to do a warm handoff and be able to immediately take some of that time and translate that into a new visit, new encounters. And that new encounters generates additional revenue flow for the clinic. Revenues from the actual intervention stage, again, will depend upon the payer source. They may or may not be able to be built of ancillary staff, so adding a behaviorist as part of the care team, whether that is a social worker or a counselor or a clinical psychologist. So really doing your homework again. Again, factoring in that intervention may already be built into a per member per month case. I know in Missouri, several of the teams on the call are participating in the K2703 demonstration program, which is a patient-centered medical home demonstration for people with chronic disease and behavioral health issues, and then a per member per month reimbursement where it's expected that behavioral health be integrated. So they're very much on the execution side and already have this as part of their model. That's not the case in all environments, but increasingly popping up on the radar screen. What we've done is taken these variables, basically these 6 variables, and put together a model for you that you can begin to use. This is a snapshot of the model. I'm going to go live with the model in a second, but just walking you through, this model is a Excel spreadsheet. It allows you to change the variables in your practice. I've modeled here at a microsystem, so this is for one provider. You can do this for a whole practice site, but suggest starting with one provider. And for this particular provider, assumed a panel size of 1,500 patients and generating an average of about 4,200 encounters a year. That 4,200 you can, again, change and click that, and depending on your productivity as a team, that will change your bottom line. We'll show you that in a second. Then really looking at what your payer mix is. In this particular case, it's 40% Medicaid, 12% Medicare, 8% commercial, and 4% sliding fee scale of some sort. So you can change that mix based on your practice. And then look at what your average reimbursement, taking something that's close to your PPS rate of about $135, $136, whatever your rate may be. You can plug that in, and that starts to influence what the gains in productivity may be. You can begin what the reimbursement rates are for Medicare and Medicaid, if your state is reimbursing for Medicaid. If they're not, you can leave it 0 in those areas. You put in your hourly staff rates. This would factor in terms of lost productivity or staff training transition cost. And so for your own organization, you can put in those rates. In this particular model, we put in a fully loaded behaviorist rate, assuming it was in the ballpark of 65,000. Might be more, depending upon your environment. We have that loaded with a 25% benefit structure. Your benefit structure might be more or less. Again, you can change those variables, but that's due to an hourly rate of $39.06 with a behaviorist component, assuming 80 hours worked a year. And so all these variables then can be modified. You assume that your average scheduled visit time is 15 minutes. Some of you may use 20 minutes. You can change that. You also begin to model then for your patient population how much time could be freed up by doing these warm handoffs. So you could start to do a little bit of a sampling of a time motion study in practice and follow a provider for a day or two and look at for how many encounters, how much of the time, when extended beyond the normal time limit, how much of that time was really something that could be handled by the behaviorist as part of handoff rather than having to be done by the provider. And so you model that for your clinic about how much would be saved if we had this model fully integrated. And so a particular clinic, we've estimated about 11 minutes, and we assume an average of about 3 visits per hour. That then will factor into your productivity so that we can begin to see what the economics are. Transition training time assumed here was 16 hours of training of the care team. Again, maybe far less for you or maybe a little bit more. You have to change that. And looking at what the evidence is out there in terms of what percentage of patients actually triage in need of an intervention. The literature suggests about 16%. You can change that variable based on your own experience. Of that, you can make some conservative estimates of how much of that could be diverted to behaviorists versus being done by the primary care provider. In this case, we decided to be very conservative and say only about half of those would be able to be handled by a behaviorist or a member of the behavioral health team serving the care team. And so this particular model, when you look at the time saved based on the number of encounters, based on the percentage of patients, we create about 246 slots. If we capture half of those patients that are extending visit beyond 15 minutes and on an average of 11 minutes, that would create about 246 new slots on a basis that could be deployed to capture revenue. So let's see if I can share my desktop here, and a little bit of help from my team. It's not popping up on my slide here. Myrtle, can you give me a little coaching here? I'm trying to pull up my desktop and I don't. Oh, here it is. Share. I'm sorry. This should pop up here in 1 second.
There you go.
There we go. Let me throw up here what the real spreadsheet looks like. So if you're still following me, we can begin to look here at our spreadsheet and say, let's change some of these variables. So for this particular case study, seeing all of these parameters we put in, what this is showing that we're not getting any, we don't have any salary resource allocated for screening or time or revenue. We've built that into an existing workflow. But we're adding on a trial basis, we're going to add a behaviorist, assuming that behaviorist can be shared by 2 providers. So our share is going to be 1 behaviorist for 2 providers. So we split the salary in half. Then we assume the transition cost. The transition cost, transition cost is salary levels of the individuals of the care team times the actual amount of time. So that tells us how much we spent there. You might want to factor in then for those 16 hours what that might translate into lost revenue. That revenue would come from your average reimbursement rate times that amount of lost time. And so for this particular case study then on the screening, we can look at our screening and see what our reimbursement is. Medicare and Medicaid, in this particular example, Medicaid is reimbursing, so they factored that into that formula. We look at our gains in productivity. It assumes that we're able to get these 246 slots, and with that, we're using that 15-minute encounter and being able to capture those additional slots. That translates into that revenue stream. And on the reimbursement side, then being able to look at for our payer mix, how many patients would we gain that we're getting reimbursement from the intervention, and that generates that additional 8,700. Go up and say, you know, we're not doing 4,200 encounters, we're actually doing 3,500 encounters, and we can start to see it changes, you know, some of the variables for the practice. It's at a very low level, 2,200 encounters that we're doing, and we can see that they'll start to change the numbers around. So this model was a starting point. You need to really understand your own environment. This particular model only factors in Medicaid and Medicare. If you were to change the model and you found out that some of the payers were reimbursing, you add that in and just add another line and build in the model for somebody on your team that understands Excel spreadsheets. They can easily put that into a formula, and that would add to your business case. The goal here is really to better understand what the impact of the changes that we can make and what variables can we influence. How many new visits would we need to create and in productivity in order to pay for our behaviorist? This can help you approximate that. Dirk, if we could open up the lines to see what questions people have, and if you'll raise your hand, and we'll call on you. But we want to see if what questions arise from the use of this model, and find out if this would be helpful to you in modeling your own business case. See if there's any hands raised.
Roger, in order for folks to raise their hands, they'll have to stop sharing. And it might be easiest if you went ahead and just stop sharing for a minute. Maybe we could go back to sharing.
Okay. So let's why don't try opening the lines, and let's see what questions people have. Dirk, would you mind opening up the lines?
1 second. Let's unmute everyone. Everyone should be unmuted.
Everyone's unmuted now, so we can just continue looking at Roger's spread here.
So the question is, what is a behaviorist? It came from Alex Ross. So in this model, you determine what the behaviorist is based on your integration model. I label it here as behaviorist, but you could label it anything you want. So adding a psychologist or social worker or whatever level it is for your integration model, you determine that, and you determine the salary rate. In this particular model, they've assumed a clinical psychologist or a social worker that meets the criteria to be reimbursed by the Medicaid agency. That may be different in your environment, so you would determine that in this particular model.
Roger,
yes?
Come up with the estimated time saved by the behaviorist.
So it comes from a situation of actually in your own organization having a staff member sit in on a panel of patients for a day or two and look at the patients coming through of the time, and actually doing a time and motion study. You can model this of a 15-minute visit. When a 15-minute visit goes long and suddenly is 30, 40 minutes, how much of that additional time taken up with what might be able to be handled by the behaviorist? That is that 11 minutes in this particular model. So to determine that, you can either do an estimate or you can actually do a field study and come up with a more refined estimate, but make that assumption for your organization.
If I understand what you're saying right, what you do is you would observe a physician's visits for one whole day, and you would say, well, how many of these individuals had behavioral health needs? Well, maybe 20% of them. Of the people who had behavioral health needs, how much extra time did they take? Oh, maybe it was 11 minutes. And so it's that 20% times 11 minutes that you're working into your calculation.
That's right.
Thanks for that explanation. I guess I had one more question. Just assuming that visit could be diverted completely, because I know in our case they're doing primary care along with dealing with this behavioral health issue. So I question whether it will free up a slot. It may mean that they won't run late in the day and they'll actually get their patients done in the prescribed time. But so it would only free it up if it was strictly a visit could be handled by a behavioral health specialist, right?
And that's the difference between green hard dollars and soft dollars. This model is soft. You can make it harder by putting some additional assumptions. So let's say that you, for your organization, you could change that assumption and say, you know what, we think we're only going to be able to capture 30% of those. And so just add that parameter in and see what it does to your model. And what it does is it tells you how many visits, how additional visits would you need to create to be able to pay for your behavioral health resources, assuming everything else stays equal.
This is Tom Ray with CI.
Yeah.
I think there's a cultural issue
issue here because a lot of our providers still kind of see the BHC folks take care of their emergencies and not take care of their routine mental health issues, so they're keeping a lot of these folks, dealing with them instead of passing them off in warm handoffs. And that's one of the cultural issues I think we're going to have to work with.
I think you're right on the mark, and that's why a tool like this could be helpful to show what the impact is for the organization if we start to clarify those role changes and those handoffs and what the positive benefits might be for your organization. Right at the top of the hour, what we'd like to do is challenge you to take this model. We're going to give you the spreadsheet. We're going to ask you over the next few weeks to test it out, changes to it. It's an old rule of thumb that all data are wrong, but most are useful. So what you'd like to do is, knowing that this tool is not perfect, how could you improve it for your organization? How could you make it more real? Your own staffing numbers, your own activity numbers, your own reimbursement for your state, and see what it does to inform you about your business case. And downstream, we'll talk about how to use it, including a point you just made, Tom, about reaching out to staff and helping to influence the culture by showing them what this can do to help improve the economics and pay for resources in the organization. We'll be able to coach you on the guidance and help you through and with various questions, but we'd like to challenge you to do this during the next action period. We're going to send out some specific guidance on how to do that, as well as a monograph and the tool to help you along with that. Look at the ball to see if there's any final questions.
Okay. Thank you, Roger. Before we get to final questions, I know we, at the risk of going over our time a little bit on today's call, we just gauge whether or not the calls, we're pacing the calls correctly. We want to ask a quick poll question based on your experience of today's call and the last call that we had, whether you think the material that we've presented has been about the right amount of quantity, a little too much information, a little too little information, or and so Dirk has gone ahead and opened a poll, and so you should see it now in the bottom right corner. It'd really be helpful if you could just give us some quick feedback on whether or not we're pacing the calls right. Our concern is that we're presenting a lot of information to you, and would like to know if you need more time to digest. Ahead and let that poll go. Go ahead and answer that question if you get a chance. Just to move us along while you're answering that question, I'm just going to review some next steps project. I've reached out to most of you. I still have a couple of teams to contact to start scheduling coaching calls. You may have gotten a voice message from me last day or two, and I'll be following up with emails, and these are calls to start supporting, helping you answer any questions you may have and other activities. Dirk, want to go through the rest of the next steps?
Yeah. So we're looking at a little bit of a schedule change for some of our upcoming calls. I'll go ahead and close the current poll because I got to open another one. Looks most of you have answered, and don't forget to hit submit. Looks like you all did. Okay, so I think everyone's very happy with the poll, with the quantity for our web meetings. So I think we'll continue doing it as we have. So thanks for that feedback. I do want to quickly open another polling question, though. Sorry to inundate you all with polling questions, but this is just about the next meeting, and it's essentially. Right now you only have a week until the next call is planned, and we're not sure if that's necessarily enough time, but we also want to be respectful of your time in the sense of switching these calls isn't always easy to get everyone around. So if you could just let us know if you'd prefer to stick with the plan and have our next meeting a week from today, same time, same place, or if you'd maybe like an extra week, because we do understand that you may have some questions about the business case worksheet, along with some of you are still a little behind on the other tools that still have to go in. So we understand and we're willing to give you a little bit of an extension. So if you can weigh in and let us know if you want to move it back to January 24th. Again, we do understand that it's sometimes tough to get everyone together on such a short notice. The second thing is that the February 21st call is going to have to be moved to the 28th. That's not going to be a democratic process due to some other scheduling conflicts that came up. So that the was currently scheduled on the 21st is now definitely on the 28th. Just as a reminder, there is still a call on February 7th. So looking at the polling question as it stands at the moment, most of you seem to be saying that you'd like more time. So if you disagree with that, make sure that you vote. But if we stick with the 24th then, so 2 weeks from today, the next one after that would be the 7th of February, and then the one after that would be the 28th of February. We will post that information on the Extranet and put it on the Extranet calendar as well, update that and have that proper. I'm going to close the poll since everyone seems to have answered, and it seems to be overwhelmingly that you would like more time. So we will not have a meeting on January 17th. Instead, we will have a meeting 2 weeks from today on January 24th. So with that, I think that's everything, and I will we'll stay on the line. If you have any questions or concerns or comments, feel free to talk. Otherwise, we've already kept you for 2 extra minutes, unless there's anything else, Laurel, that you still have to say, or Roger.
Dirk, I think we're all set for today. I know we went through what is a very, we think is a very exciting, very useful tool, but we went through it pretty quickly. And as you give it a try, as Dirk mentioned, these will be posted to your Extranet folders by noon tomorrow. So you will all have access to them. Just go to the Extranet, open your folder, open resources. You'll find this Excel sheet. Give it a try, and as you have questions, as questions emerge, please just let us know, and we'll be happy to answer them for you. On the line, as Dirk said, for a couple of minutes, if you'd like to ask additional questions, but you're free to leave the call now.